This conference will now be recorded.
Thank you for making it to one of our virtual happy hours. Hopefully, you're all comfortable. This webinar is scheduled to run for about an hour. This is part of our stroke interdisciplinary special interest group through ACRM. So if you're interested in learning more about our organization, just click on the link or contact us. My email address is there. And Alex, one of our presenters, has the slides now, but if you can move forward a little bit, Alex. Those are just the next few slides, just tell a little bit more about the organization and our upcoming conference dates. So we do want to start with this very important talk, which is very opportune, the day before Valentine's Day. We're going to be talking about intimacy and sexuality after stroke. And I love the title, just to say. But we have two presenters who are very, very pleased to have Dr. Alex Terrill, a clinical psychologist, who is an assistant professor at the University of Utah, Department of Occupational and Recreational Therapies. And along with her, her partner, Paige Salinas, who has a background in social work and is the clinical director for learning services in the Rocky Mountain region of Colorado. So both of our presenters come with a lot of interest in research with disability, relationships, and self-management, a lot of things that are very, very important and, in my opinion, a very underrepresented topic. So without further ado, I do want to bring you Alex, first of all. Thank you.
Yeah, thank you so much for the introduction. We're really excited to be here and talk a little bit about sex and intimacy after stroke. We have nothing to disclose. And for this talk, we'll explore some changes and challenges with sexual activity and intimacy after stroke, and also learn how to address sex and intimacy with patients and their partners. So we'd like to start our presentation with a brief case study. This is Fran. She's a 59-year-old woman who sustained a left hemisphere ischemic stroke 6 months ago. She's being seen in an outpatient clinic for follow-up. The good news is she has regained most of her gross motor function in her right upper extremity, though fine motor is still a bit more difficult for her. She continues to experience some expressive aphasia, but has also made good progress there. Her provider sees this and says that Fran is doing really well, to which Fran says she knows she should feel good about where she's at recovery-wise, but she just feels blah, gets fatigued easily, and she feels like everyone, including her husband, acts like she should be back to her normal self, but she just doesn't feel that way. She adds, and sex? I don't have a lot of interest, and I really feel it's hurting our relationship, and we don't talk about it. I have a hard time finding the right words. The provider feels uncomfortable and unsure how to follow up to this, and instead changes the subject to ask about how she's doing with etiologies like dressing and whether she's thinking about going back to work. This is not an uncommon scenario, and we often hear that our patients would like more information about sex and intimacy after stroke, but it's not something that is typically talked about for various reasons. We hope that the information we'll share with you this hour will help shed some light on factors involved in sex and intimacy after stroke and how to better address these issues with your patients. So we'll start by briefly giving an overview of the most important sex organ, the brain. One study on women found that as many as 30 areas of the brain are active leading up to and after orgasm. So there's a lot going on in the brain. Here's just a list and a figure of the area of brain activation during and after sex. And as you can see, there is so much going on. So let's look at this in more of a play-by-play overview of what happens to the brain before, during, and after sex. And just this caveat that this is a very brief overview. So desire starts with sensory input or cognitive processes, and there are a number of regions of the brain that kick in when people feel sexual desire. As might be expected, several of them are in the temporal lobe, so the limbic system and cortical areas, and one of those regions, the amygdala, orchestrates powerful emotions. It's part of the circuit that is thought to be responsible for pleasurable feelings. The amygdala has been implicated in processing mental aspects of sexual arousal, and it helps us evaluate a stimulus as arousing or not. And if there's lesions in this area, these have been related to aggression, sexual preoccupation, and interestingly, hyperreligiosity. So in the desire phase, the amygdala has selected incoming sensory information as very critical and worth noticing. Then another, the hippocampus, involved in memory consolidation and information integration, might actually become active as we associate sights and smells with past sexual experiences. All of this leads to sympathetic nervous system activation, which peaks during orgasm. After orgasm, the parasympathetic nervous system is activated and slows us down to normal again. But sexual experiences are not just a matter of primal emotions and associations. Some parts of the brain that light up in the fMRI scans include regions that are associated with some of our most sophisticated forms of thought. The anterior insula, for instance, is what we use to reflect on the state of our own bodies. So being aware of kind of the sensation of butterflies in the stomach, for example. And brain regions that are associated with understanding the thoughts and intentions of other people also seem to be linked with sexual feelings. Finally, the nucleus accumbens is the pleasure center of the brain. Anything that is pleasurable will activate the nucleus accumbens as dopamine, a neurochemical messenger associated with pleasure, reward, and reinforcement, flows into this area and gives the message, that was fun, felt really good, tasted good, smelled good, don't forget, do this again. And this provides reinforcement to repeat the behavior. So as you can see from this very brief overview, areas all over the brain are involved in sex. It's no wonder then that sex and intimacy might be affected when there is an insult to the brain. Depending on where the stroke occurs, it can have different effects on sexuality. Strokes in the left hemisphere can cause hyposexuality, which is hypothesized to be due to dominant hemisphere language and motor deficits, as well as reactive and or organic depression. Stroke in the right hemisphere, especially in the right orbital frontal region, tend to be related to hypersexuality, as this is a region of the brain related to regulation and inhibition. If we see strokes toward the front of the brain, this may impact motivation to engage in sexual activity, the ability to initiate sexual activity, impulse or inappropriate sexual activity, and the production of language and ability to communicate, whereas strokes towards the rear of the brain can impact awareness of issues that need to be addressed, so neglect, the understanding of language, and the ability to communicate. Cortical areas are involved in the initiation, drive, and activation of sexual activity. Subcortical areas play a more behind-the-scenes role. Brainstem manages input and output of sensory and motor information, and also manage arousal and alertness. And parasympathetic system actively involved in genital sexual functioning. And so strokes that affect any of these areas can affect sexual functioning in these ways. In addition to the stroke itself, there are a number of health factors that can also impede sexual function. Issues with blood supply or blood flow, as seen in conditions like atherosclerosis, can affect blood flow to the sex organs. Hormonal changes like reduced testosterone or thyroid hormones may also reduce sex drive. And as you may note, many of these conditions are risk factors and are often comorbid with stroke, so we often have more than one thing to contend with. Bowel and bladder issues are also common health problems, sometimes resulting from the stroke itself, and this is something that patients tend to report as particularly bothersome or impeding their interest and ability to engage in sex. So because I'm a psychologist, I would be amiss not to bring up depression as another important factor that can impede sexual functioning. Depression is extremely common after stroke and may have an organic etiology or be a psychological reaction to the effects of the stroke. Reduced libido is one of the hallmark symptoms of depression, likely related to anhedonia, reduced motivation, and reduced self-efficacy. It is of note that the medication prescribed for depression might also contribute to a suppressed libido. And finally, many patients and their partners have a fear of having another stroke during sex. The likelihood for this is relatively low, but it is something that should be addressed by the healthcare provider if this is a concern for the patient. Understanding both physiological and psychological correlates of your patient's stroke can help to anticipate and effectively treat co-occurring sexual dysfunction. We've covered some of the physiological correlates, so the direct effects of stroke, and we'll now transition into more of the psychological correlates. So first, let's talk about some of the broader psychosocial effects that stroke can have on a person in terms of their role, self-image, and how their partner views them. Changes in roles are common following a stroke for both the survivor and their care partner. They can take on new roles, such as that of a caregiver or reassigning household tasks. And there are also role losses or reversals. For example, the primary provider is no longer able to work. But one of the really important role changes that happens in an intimate relationship is that a couple may go from being spouses or partners to a caregiver-patient relationship. And these new roles are often dissonant with sexual and romantic roles. Here's a smattering of things that we've heard patients and their partners express about themselves and their relationship post-stroke, and perhaps you've heard some of these yourself. My body doesn't work the way it used to. I'm not sure I can perform. I'm being treated like a child. I feel like a burden. To, I worry you will have another stroke. Your personality is different since the stroke. I feel like a parent, not a partner. Coping with stroke within romantic relationships can be stressful, adding and changing tasks and roles to an existing relationships. Shifts in roles can strain relationships and may disrupt defined gender roles and patterns of interaction. Younger people may be more overwhelmed or feel personally devalued by their new role as patient or caregiver, and so often they might prefer being referred to as care partners. How long a couple has been together matters in how this affects their functioning as a couple. In longer relationships, where roles are more firmly established, we tend to see more loneliness. Whereas in newer couples, the individuals feel a greater loss of autonomy. In terms of differences between men and women, generally speaking, men tend to report more significant shifts in their marital roles after a stroke. But some studies, including some of our pilot work, has found that many couples also report that they have been able to adapt to the changes caused by stroke, and that the relationships have gotten even stronger after the stroke, as they have found a new appreciation for each other and have found ways to enjoy doing activities together that has actually brought them closer. Another issue that can impact sexuality after stroke is the self-image. So there can be a sense of loss and functional changes that affect sexuality. And conversely, changes in physical and sexual functioning can affect confidence and a sense of self that changes after changes in body function and appearance. Stroke survivors may not feel attractive and perceive their bodies as fragile, unfamiliar, and unreliable, and sometimes even betrayed by their own bodies. These changes can lead to shame, frustration, and depression in both the stroke survivor and their partner, hindering sex and intimacy. On the other hand, how the partner perceives the stroke survivor may also affect sex and intimacy. The partner may be bothered by some of the sequelae of the stroke. There is often an incongruent appraisal between the stroke survivor and the partner. Partners tend to actually have more negative appraisals of the survivor's physical and cognitive function, and the mismatch can often leave the partner feeling overprotective or overly cautious, and the survivor feeling misunderstood and frustrated. Not surprisingly, couples who have these incongruent experiences are more likely to experience poor adjustment following a stroke. Cognitive impairment is particularly difficult to deal with. It's actually, conditions with cognitive impairment are amongst the most difficult for couples. One of the reasons for this is that the person who had the stroke may seem like an entirely different person to their partner, and this transforms the relationship. And then there's the issue of mutual consent, which is really difficult to deal with. Stroke survivors may be either painfully aware or lack insight into the impairment, depending on the severity of the impairment. And although there might be a loss of cognitive abilities or cognitive abilities are compromised, sexual desire often remains intact and is sometimes even escalated. At times, one partner, either the person who had the stroke or their partner, may lose sexual interest. And clinicians should always be on the lookout for concerns of abuse when the person who had the stroke has cognitive impairment. Really, there's no clear cutoffs or directions for how to deal with this, but communication between the partners and the provider is absolutely key, and we'll talk more about this later. So what are some things that might help? Partners and stroke survivors may have difficulty separating their role as caregiver and care recipient with roles as sexual partners. And so sometimes hiring someone to assist with care, especially in bathing, toileting, might be helpful. Working with occupational therapy to assist with strategies for dressing and toileting can also be really helpful, because even slight modification can greatly increase functional independence. Plus, resumption of sex can be a great motivator to become more independent. It's really a win-win situation. And with that, I'm going to turn it over to Paige.
All right, thank you so much, Alex. So we're going to kind of piggyback on what Alex was talking about as it relates to the relationships and the changes within the role of the survivor and the caregiver. So we're going to move into sexual relationships and intimacy. So one of the things that I think is a great takeaway from this presentation today is to really think about sexuality as a whole. It's not just about sex, it really is a part of our lives. So when we look at sexuality, we're really taking a look at the physical, the spiritual aspects, and psychological aspects. So it may not even be just sex that contributes to who we are as a person and how we identify our sexuality. It can be whether we feel masculine or feminine, our sense of worth, how desirable do we feel, how attractive. As we get ready to go out, on the town and have a nice dinner, we get dressed up because that's a part of who we are, and we feel good about ourselves in the sense of our sexuality. How affectionate are we? And then how well are we to receive that affection? So all of these things play into a stroke survivor in the sense of how do they feel post-injury? What is their sexuality like pre-morbidly? And then as we're taking a look and exploring this with stroke survivors, how would they define their sexuality currently? So when we talk about sexuality, it does change throughout a life cycle, right? When we think about hormone changes within our teens, and then when we're going through our 20s and 30s, that changes and is different for men versus women. Our sexual drive changes throughout our life cycles, as well as when we have a disability that can definitely impact our sexuality through that life cycle. In addition to lifestyle demands, thinking about being a mother and a wife and working full time and going to school, we're going to think about all of those competing demands and the lifestyle that we live at times, and think about how does that impact not only our sexuality, but our sex life within that life cycle. So there's definitely some common myths when we talk about disability. And so I love this quote from Medler. It says, acquired physical and mental impairments may significantly alter, yet do not eliminate basic sexual drives or human needs for affection, intimacy, and a healthy, positive self-concept. So the next slide, we're going to kind of take a look at fact or fiction. And I think it's interesting because I think sometimes even as healthcare and rehab professionals, we sometimes get sucked into these statements or these thoughts that are actually very much fiction versus fact. And so it's really our role as healthcare providers to really hold ourselves to a higher standard as it relates to sexuality, but also be holding others accountable within our profession to ensure that we're not having these myths or fictitious thoughts and statements in our healthcare centers. So some of these are brain injury survivors are not actually interested in sexual activity, right? That would obviously be fiction. Older adults are not physically capable. You're going to offend a patient if you actually talk about sex. So it's actually better just to let them initiate the topic, right? Masturbation not allowed in rehab settings. If the patient, again, doesn't bring up the topic, then it must not be an issue. And I think we kind of saw some of these myths and fictitious statements when looking at that case study that Alex presented at the beginning, where the physician was uncomfortable and therefore it was like, well, this doesn't need to be a medical issue that's addressed because of my level of discomfort. So obviously it's not that big a deal and we can move on to talk about, kind of where you're at with return to work and your basic ADLs. So a lot of these are very much fiction versus fact. And I think it's important for us to hold ourselves accountable to thinking about how often these really do happen in our healthcare settings, whether we want to admit that or not. So I think the other thing is when we look at the phases or stages of the continuum of care, we oftentimes think maybe more in an acute inpatient setting that it's not really the right time or place to start talking about those things or broaching that topic. So we oftentimes think, well, they can deal with that when they are further along in their recovery, when they're outpatient, when they're back home. And as we will continue to talk about, that's really something we need to include in our initial assessments and our initial interventions within whatever setting we may be working with this stroke survivor in. So let's talk about intimacy a little bit. It kind of goes along with that sexuality piece of it's not just about sex. So when we think about our intimate relationships, think about intimacy across the board. So whether that's a romantic relationship or a platonic relationship or even a working relationship, there's some level of intimacy and rapport that we have with humans. And I think it's important to understand how much we really do rely on intimacy in our lives, and of course to degreeing levels depending on our personality and characteristics. But then we also throw in the disability of a stroke and how that impacts our intimacy, and I think it's important that we take a look at that. So intimacy can happen with and without sex. There's definitely that physical intimacy. It may just be a touch on the shoulder. It could be holding hands. Thinking about a lot of times when we see our patients that go back home and they're spending time and quality time with their loved ones, it may just be kind of that cuddling on the couch, spending quality time together, and really taking a look at how we can express to one another those verbal expressions of love. And so I think it's important to really get creative in the ways that we want to help foster and support stroke survivors to get back into those intimate relationships with their partners, with their families, with their friends, so that they can receive that level of intimacy that is obviously from a psychological perspective going to be beneficial to their recovery. There's definitely some intimacy factors we want to take a look at when we are working with a patient, and maybe it's a spouse, maybe it's a partner, maybe it's someone that's single and we just want to kind of explore what their intimate relationships have been like. We want to take a look at what were those pre-injury relationships. Oftentimes, I think we would all agree that our clients, our patients don't come to us in a pretty package, right? Where they have a wonderful marriage and a supportive family and their marriage is solid and they're going to see themselves through anything. Oftentimes what we see is a lot of maybe some dysfunction, family dysfunction. We may have some marital issues that they were on the verge of getting a divorce prior to the stroke. And so those are all some contributing factors that we need to take into account when we start working with these patients, understanding what their relationships were like. What was their communication style? Were they able to have effective communication within a healthy relationship, or did they tend to kind of get mad at each other and become verbally aggressive or ignore one another for a period of time. What were the individual's coping skills as well as their partners, and how do those intimacy factors play into something as we're trying to get them back into those relationships, reintegrating back into the home, and fostering those relationships. So things to think about as far as kind of what are their social supports, what was their prior experience and their coping skills, that unconditional unselfish love, or is there some issues with the caregiver feeling burnt out and not wanting to care for the stroke survivor at this time in their recovery, and there's a lot of just unresolved issues and possible resentment from the relationship prior to the injury. So these are intimacy factors that we have to be able to explore with our patients and their families to have a full picture as to what did it look like before, and then where are we going to get as we set some goals within these sexuality realms with the clients and the patients and their families. So as Alex talked about, the spouses, the partners, the loved ones in a patient's life quickly turn into caregivers. And as I was talking about some of those resentful feelings and the caregiver burnout, there is going to be times where those caregivers may experience guilt related to their own unmet sexual needs. Obviously, there are times in the acute care where that is not going to be a priority, although it should be assessed and there should be intervention. They may not be able to be intimate in that setting. And so really there are some things that we need to identify within the families as to what are they experiencing. Is the caregiver on board for long-term caregiving, in the sense of whatever the level of assistance that is needed for that patient? When we all know that there is caregiver burnout, and when they are not practicing self-care, that unfortunately can have ramifications for the client or the patient as well. There's also mental health, as Alex talked about, with depression, increased anxiety. There's, as we all know, when we are resuming those roles, there's a level of anxiety that accompanies that, right? When we're talking about patients that are ambulating for the first time or going up the stairs the first time, we see increased anxiety with that as they're relearning those skills. The same will happen within sexuality as well. So when we talk about kind of being intimate physically, sexually, and emotionally, we may see some increased anxiety that we need to be mindful of as we're working with these patients. And we also need to be able to support them in their new normal. And so allowing the patient and the families to understand that these emotional adjustment issues that they're experiencing are very normal. And so we want to help navigate that with them so that they can understand some of the changes that they may experience short-term and also possibly long-term. I touched on this a little bit, so I won't go too much into this, but I think we really have to assess the quality and the strength of the pre-stroke relationship. So what were their coping skills, communication styles, their ability to understand and empathize, their frustration tolerance, as we talk about patients and caregivers, how well are they adjusting to the injury itself? How well is the caregiver able to empathize with what the patient is going through? Their spirituality is an important factor. So what higher powers do they lean on or rely on to be able to get through these difficult times? And so as we're continuing to talk about assessment and intervention, I think that's a huge piece as we do our psychosocial assessments to fully understand the full picture of the patient and the family's lifestyle. So a couple of studies noted on here. So a survey was done with spouses of stroke survivors, and within those items, 19 areas of concern were identified, but sexuality was actually marked as the greatest change. So when we are asking individuals, specifically spouses, they are able to acknowledge that, right? And we're going to talk a little bit about the initiation of that topic versus retrieval of information about that topic. So this was obviously a survey that was asking a pointed question about sexuality, but I think it's interesting, and we need to be able to identify that that is a change, a marked change for them. Oftentimes spouse and partners tend to be in that survival mode, right? They're focusing on the needs of the patients. Their primary role is to be caregiver, which is very much different than their role before. And so it's important that we talk about and educate and provide counseling on self-care and burnout prevention for caregivers. But on a positive note, a qualitative study was done for individuals post-stroke 6 years, and the findings were that some stroke survivors were reporting increased intimacy, therefore reporting positive changes. So as we talk with a lot of our patients that have suffered a stroke, there are great opportunities to see something positive within this. I oftentimes hear patients say, this was a wake-up call for me. This was my second chance. My life perspective is so different and so changed, and now I have new goals. I have a new direction, and that can happen within those relationships as well as they continue to go through challenging situations in life. Oftentimes, this stroke may bring those couples closer together. So now we're going to move on to treatment and interventions. So again, the communication piece is really important for us to be able to identify, because as we know with stroke survivors, oftentimes there are cognitive impairments that can have an impact on the relationship that they have with their spouse, partner, and intimate relationships. Obviously, aphasia is a large symptom of stroke. And so we want to be able to talk about coping skills and compensatory strategies to be able to foster effective communication between the patient and their loved ones. Oftentimes, we also know that there are personality changes with increased irritability. They may not be able to have as quick of processing speed, or they may have some disorganized thinking. And so what we want to be able to do is work on those and hone in on those skills as we would within any rehabilitation setting. But we also want to tailor that to, okay, now these skills, whether it be effective communication, processing speed, thought organization, those types of things, we want to be able to tailor it to, okay, now how does this work when communicating with your loved one, right? What are some emotional discomforts and how do you want to be able to communicate that to them? Or if you want to attempt sex for the first time with your loved one, how do you effectively communicate that? And so really being able to walk them through that so that they can understand, what that would look like. If that for the first time there's some frustration because there is some physical challenges or the libido is altered, we want to be able to talk through that and give them the tools and the skills that they need to be able to effectively cope with those changes, but also have that effective communication with their partner so that they can talk through any issues and barriers they may face. So, of course, counseling is a huge part of being able to have a safe space to be able to have the couple come in together as we talk about ways to effectively communicate, as we talk about building that trust and reestablishing that relationship and that rapport with one another. How do they have patience as the aphasic patient is trying to communicate their needs, but having difficulty retrieving the words and being able to articulate that to their partner? So really fostering a safe environment so they can learn active listening skills. There may be some communication methods such as an iPad or a marker board so that they're able to effectively communicate those sexual needs. So obviously treatment for sexual dysfunction is going to vary depending on the actual diagnosis and need. So from a pharmacological perspective, there could be some medicinal interventions that are provided. Obviously, we would want physicians' involvement and input from that perspective if there's any type of surgical interventions that are necessary. But then we're also going to have the interdisciplinary team being able to approach this topic with the patients and the families. Specifically, when we're looking at some of the positioning and physical challenges and barriers that patients and families may face, we want to get them in the involvement from the physical therapist and occupational therapist. From a cognitive perspective, we're obviously going to have the therapist involved with that. obviously with speech and language pathology, but also across the interdisciplinary board, right? We've got neuropsychology and counseling, and then all therapists really do have a part in this. So it's important, though, as we approach these topics, that we feel knowledgeable about the sexuality issues within stroke recovery. And as treating clinicians, that is our responsibility to become knowledgeable about that. The level of comfort, we're going to talk about that a little bit later, but that level of comfort is really important, that we are able to consistently screen for concerns that the patient and the partner are having. So this is just a list of recommended sexuality curriculum. So we want to be able to identify that there are sexual values that we need to be able to be respectful of. Not only respectful of, but truly understand. So when we're doing our psychosocial assessments or our initial evaluations, even from a PT perspective, we want to be able to talk about, prior effects of illness and injury on sexuality. Are there any STDs, sexual assault, or changes in the relationship with self and others? We want to be able to provide education to the healthcare professionals so that they can advocate for the patients and their needs. So I think that there's some sexual language and that we could talk through with the therapist on their communication skills and how they're approaching the patients and the families within these topics. And I don't think that every single therapist or clinician is going to cover all of these specifically within the curriculum, but I do think that this needs to be across the interdisciplinary team as they're taking responsibility and initiating these conversations with the patients. There's definitely barriers that I think we should openly identify to addressing sexual functioning within rehabilitation. If you've talked with any of your staff before about this topic, there's probably going to be someone or someone, in plural, that is going to become uncomfortable with this topic, and that's okay, because the more we can put it out there on the table, the more comfortable you are initiating this topic, the comfort level is going to increase. But we have to get the topic on the table first, right? So these probably seem very familiar to you guys, seeing people avoid this topic, not really feeling like it's their role. So, that's probably for the counselor, the psychologist, the neuropsychologist, let's let them handle that. There may be some cultural biases. We may really have some of our own bias that we're not able to identify or not willing to identify. We may have judgment on some sexual behaviors and sexual lifestyles of patients. And I think that's something that we have to be very conscious of ourselves. But really, there is definitely inefficient training and support for staff. And so that is our responsibility as healthcare organizations and healthcare providers, is to be able to educate our staff, to be able to support them in getting the training and the education that they need to be able to have these conversations, so that it does become a part of our routine assessment and our routine treatment interventions for patients that we're treating. With that being said, there has also been an increase in identifying the needs to address sexuality post-acquired brain injury in recent years, which I'm very excited about. So, for example, CARF, which most of us are familiar with, is Commission on the Accreditation of Rehab Facilities. They are continuing to identify ways for organizations to have standards that are related to a person's sexuality and how that acquired brain injury is impacting that sexuality. And then also having standards for the healthcare organizations to have rehab professionals that are addressing this with their patients through education and counseling and therapeutic intervention. So this is an exciting time where all of our organizations, specifically those that are CARF accredited, are being held to a higher standard where that's not being ignored. That is something that is a CARF standard and should be, there should be conformance to. Interestingly enough, and Alex and I have done a presentation with an individual from Sweden, but there is patient-centered care in Sweden that is required by law, and sexuality as a part of patient patient-centered care is actually emphasized in stroke rehabilitation in Sweden. So, you know, as we all know, we can all learn from one another, and I get excited when I see other countries, other organizations really putting this as a priority when working with patients, specifically those with disability that don't need to have this topic ignored. This is something that has been around for a very long time, the PLISSIT model. It does address sexual functioning, and it really kind of gives a framework for organizations to kind of know some boundaries and some role differentiation of who should do what and at what point. So permission is great. I think we can do that on any and all levels of giving the patient permission to be able to talk about sex, or to talk about sexuality, or to talk about some issues and barriers that they are having around sex and sexuality. So that could be anywhere from a neuropsychologist to a physician to maybe a rehab technician. Those things could be talked about openly, just as you would talk about, you know, having toileting issues or having dressing issues. Now, when we go from permission to limited information, this is really being able to provide patients with some information on a very basic level with limited information based on your own expertise, right? Then when we go into specific suggestions, that's really taking us and elevating us to a level where you would need to have, it would be necessary to have that expertise, being able to make specific suggestions based on a full evaluation of presenting problems. So that's more of the clinician level, right? And then when we move into the next stage, that's more intensive therapy. So that's being identified that this is outside of your expertise. You're not able to provide them any more suggestions than what you've already provided. So then it would be necessary to refer to intensive therapy. That might look like sex therapy or biomedical approaches or psychological interventions. So what can we do? We can maintain always an open and honest and professional approach with our patients. The more comfortable we are with approaching this topic with patients and families, the more comfortable they will become. So don't apologize, don't act skittish when bringing up this topic, but really ensure that you are properly educated about how the medical conditions you treat impact sexuality. Your job really is to help facilitate health promotion and modification, right? What we want is to be able to become educated ourselves so that we can educate patients and families, and that we can promote health and wellness within their recovery. This is a model, another model that's called intentional relationship model. It's based on therapist knowledge, understanding and acceptance of self, along with mindfulness of the client's status and situation. This model really focuses on empathy and ethics. Mindfulness is a big portion of this as we continue to display compassion and courtesy and respect and confidentiality. When we think about those words or those terms, that just seems like, well, that's just normal. We should do that always, right? But this is a model that really brings us into focusing on the specific topic, being able to display good interview skills, having the correct body language that we need to be able to talk about this topic with patients, and being able to be assertive as we communicate with the patient. Interview techniques are something as well as we're doing those psychosocial interviews or our initial evaluations from the therapist. We want to be able to move into these sensitive areas as we're talking, right? So we're talking about how often did you stand or walk before, and how much exercise did you do? And then it gets to that place where you want to kind of move into more of the sexual related topics and questions. And that's where it becomes a little bit more challenging, I think, for therapists to be able to dive into. So these are some interview techniques that may be helpful so that we can bridge those statements to incorporate sensitive topics within the interview. So some of the examples would be, has anyone talked to you about your injury and how that can affect your ability to have sex or to be in a sexual relationship? And I think sometimes we often have this myth or this this fictitious thought that if they're not married, if they're not in a relationship, then maybe we shouldn't bring up sex, right? But I think this is a great question to be able to bridge and ask those questions, no matter if it's on their intake sheet that they're in a relationship or not. So one of the things you may ask as well is, since your injury, has your relationship with your significant other changed? Do you have concerns about your safety and your communication with your significant other? Were you romantically involved with anyone when you were injured? That's a great question when we don't see someone tied to their care. And then also, has your libido or interest in sex changed? Those are important to ask as well. So as I've mentioned throughout this presentation, sexuality and sexual health is a part of activities of daily living. So just when we talk about dressing and bathing and grooming and hygiene and what was your routine, let's talk about what was your sexual routine. How often were you sexually engaged? Did you have multiple partners? Those types of things. Then when we talk about wanting to resume and reintegrate them back into those roles and relationships, we want to talk about those positioning pieces and what are some barriers and challenges that you may face based on these physical impairments. We also want to assess for the emotional and cognitive pieces as well, as we've talked about. But again, this should be a part of our assessment. So when we're doing our ADL checklist, let's also add sexual health to this. Again, positioning can be something that can be provided by our clinicians with therapeutic interventions. So the OT and PT specifically teaching them specific positions, because as we all know, their bodies have changed, their abilities and functions have changed. And so we want to be able to play an active role in helping them find comfortable sexual positions. That could be done in a gym on a mat. And that's really something that we want to be able to set them up and ensure that they have good balance, good stamina, good endurance. Just as you would treat any other physical disability and impairment, we want to be able to incorporate getting your shirt on. We want to do that within the therapy gym. We also want to do sexual positions within a private, treatment room to be able to allow them to understand what positions they potentially could do. Even if they're wheelchair bound, that might be something that the OT or PT may want to explore with them as to how could you still be sexually intimate with your partner and be in the wheelchair. If they are single, that doesn't mean that they don't have any sexual needs. If they're not even sexually active with another person, that doesn't mean that they don't want to engage in some type of masturbation or self-fulfilling sexual activity. So I think it's important to really kind of talk about alternatives for sexual satisfaction, and including lubrication when natural lubrication is reduced as a result of the injury. So these are things, again, not to shy away from, but to be able to bring to the forefront and let them know that we are a resource and we are a support system for them to be able to resume their lives in all facets. So this is kind of just a summary. We are really recommending that we all in healthcare approach the topic of sexuality. It is a valid health issue that should be addressed in all clinical settings. And the individual who does address sexuality should really have an adequate understanding of their own sexuality to reduce the likelihood that their own personal views would be imposed on the patient or the client. Again, understanding your own biases before you move forward with working with individuals. But it really should be dealt in the same manner as any other important issue that we address in our healthcare settings. So please know that rapport is a huge part of that therapeutic tool, and we all play a role, and we can work together to determine our own specialties, our own expertise. But the more we can talk about it, the more positive outcomes we're going to have for our patients and their overall life satisfaction, because sex and sexuality is a big piece of that. So we're going to move back to the case study on Miss Fran. As Alex spoke about, this is a stroke survivor, a 59-year-old woman. And as she was talking, she was having a lot of concerns, right? She was feeling like She was being pushed into something that she didn't feel ready to do. She was able to identify that her husband was wanting some things, and she just was feeling a little bit insecure about the progress that she was making. She had brought this to the attention of her physician and was quickly dismissed because of his level of discomfort, right? So we'd like to kind of open up this dialogue, if you could unmute yourselves so that we could talk through and just hear from you as the audience as to what are some factors to consider and think about as we look at this case. What questions would you possibly want to ask Fran? And then what recommendations would you make for her based on what you've learned here today within this last hour, but then also within your own expertise and experience when working with stroke survivors around this topic?
I guess I can try. This is Cecil. I guess I probably could start broaching the subject by asking about concerns about her role as a wife or as a partner, with being able to fulfill any of the what she perceives as her sort of responsibilities or duties as part of this. Kind of like a more general question to see where she would go with that.
Okay, I think that's great. I like that you're being patient-centered and you're really making it about what is her perception, what are her fears and concerns, to better understand where she's coming from so that you could make those recommendations for her. Anyone else on the line have some thoughts or things to consider as we look at this case?
If not, we can make some suggestions.
Yeah.
For example, given her kind of initial statements about feeling blah and being fatigued, maybe we should look into depression. Is she depressed? Are there medications that she's on that might be affecting her libido?
The other thing I might ask is what was how would she describe her sexual health before the injury, so that we could better understand maybe some of the expectations of the husband. I think being able to identify how as Alex is talking about, how some of those symptoms are impacting her drive and desire to resume sexual intimacy with her husband, but also getting some history on what did that look like before and how different has that changed. What are the role changes and responsibilities within that, and that might be able to help us understand where some of those fears and concerns are coming through.
Absolutely. I think probably in the interest of time, we'll move it along.
Yeah, so thank you, each and every one of you, for joining us today. Alex and I have been working together for quite some time around this topic and starting dialogue with healthcare organizations, and I think it's important that we continue this dialogue, and that each and every one of you take that back to your organization if you're willing, because I think this is a topic that we need to be able to initiate within our own organizations and be able to equip our clinicians with education and training in this area so that we can continue to impact patients' lives.
I actually want to bring on Marlene as part of the Stroke ISIG Health and Wellness Task Force, because Marlene invited our speakers to speak today for a virtual happy hour.
Hi, everyone. Yes, thank you for attending. Thank you for joining us.
I can't hear you too much, Marlene.
Hello, can you hear me any better now?
A little bit.
Okay. So I want to extend thanks to everyone for joining us this evening, and also a special thank you to Dr. Terrill and Paige Salinas for bringing this topic to us and discussing the ins and outs and providing us recommendations, practical recommendations. I do just want to remind everyone that is here attending that the webinar is going to be available in about 48 hours so that you can share with other colleagues. It's going to be posted on Vimeo, YouTube, and the ACRM video resource page. And you can find that resource page through a link if you go to the Stroke ISIG webpage. So thanks again for joining us. And if you have any questions or are looking to get more involved with the stroke care transitions and health and wellness, please feel free to reach out. My information, my contact information is also on the Stroke ISIG webpage.
And thank you, everyone, and have a good rest of the evening.
Thank you.
Thank you.